So we're going to switch gears a little bit. You've heard about the regulatory frameworks and just the legal and the emerging policy kind of framework. I'm going to talk a little bit more from the perspective of what do you do when maybe one of your patients starts to talk about this. How do you react? How do you respond? What do you need to know just on the ground that might help frame it? Because really, we don't abandon our usual kinds of ways of approaching patient. There's an assessment, we assess, we decide, we make decisions, we go forward from there. So I am the Executive Director of the BC Centre for Palliative Care. We're a Ministry of Health funded organization, and so part of the goal of our organization is to promote person-centered care and as well to improve access to an integration of a palliative approach to care, which will really be the topic of what I'm talking about today, as well as advanced care planning and other ways that people can make their decisions known. Just to say as an exclusion, this cannot be requested in an advance directive at this point. So I'll be talking about what is a palliative approach to care, how can we assess and support our patients who request hastened death, and I'm using that terminology because I think it makes clear what's actually at stake here, and then how can we support each other. Because for many people, either whether you're for or against, this is a time of high emotion, and we want to be able to move past the for and against arguments to having kind of a reasonable, thought-through approach to this topic. So these are really old studies, but they're still valid. I've been part of several studies that have repeated these questions with patients and families, and we come up with very much the same things. When you ask patients and families what's important to them at end of life, they tell you that they don't want to be in pain. They want to have a sense of control. They want a clear approach to decisions and roles, and I'll talk a little bit more about what that might look like for us. They want a chance to, even in the midst of advancing disease and potentially other issues, to still be who they are, to still be able to do relationships and do the things that are important to them and not be a burden for others. And that who they are would still continue to show up, that idea of person-centered care. I am a person, I'm not just a patient with a diagnosis. I have family, I have a culture, religion, and other things that are important to me, and that those need to be respected. And the other thing I think we've lost a little bit, and if any of you have read Being Mortal, I highly recommend it by Atul Gawande. He talks a lot about how we've medicalized aging and death to the extent that we've kind of lost the sense of what can a person do in this last stage of life to prepare for life's end, to continue to strengthen relationship, to bring meaning and a sense of completion. So when people are asking for hastened death, because I've had patients now who've asked at the beginning of a diagnosis saying, I don't want to go through that, we can sort of help them understand that there's still meaning and purpose in this time of life, to create legacy, to do work within relationships, and to do some life review. So what is a palliative approach to care? Really, it's person and family-centered, evidence-informed care. And there's more and more studies looking at some of the language with this. Sometimes can be early palliative care, but what we're looking at with the integration of a palliative approach is it's not just those people over there who do this, but all of us who care for those who are dying. It involves person-centered care. You have to ask, what are your goals? What are your worries? What are your fears? What are the trade-offs you're prepared to make for more time? What are some of your priorities? And to be able to give them the information so that they have time to do their bucket list if that's a priority for them or not. And that a bit of a roadmap is provided so that they can know if I'm going from Vancouver to California, there's 2 or 3 different ways to get there, and what are the advantages and the disadvantages of each one. A focus on pain and symptoms is really just to reduce preventable suffering. We know most pain can be effectively treated, and so people shouldn't have to live with untreated or unresolved pain. So really it's about helping people live as well as they can for as long as they can, a focus on life and living, and really within a palliative approach to care that death is a natural event. It's something that happens, 100% of us will die. This is something we can plan for, we can get comfortable with, we can talk about in a way that people can make their plans. So team support is important. No one person can do this. And we, in palliative care, focus not just on the patient, but also the family as the unit of care. And that care doesn't stop when the person dies. It also extends into bereavement, because a poor death continues to have poor outcomes for family members, which show up 3, 6, 9 months later as depression, PTSD, anxiety, and other symptoms. So palliative care, as a philosophy of care, neither hastens or prolongs death. So this is part of the current debate, and this is the World Palliative Care Organization, the Canadian Hospice Palliative Care Association, the Canadian Society of Palliative Care Physicians, trying to help people understand that we accept death as a natural event, and we don't do anything that would hasten or prolong, and that it needs to be adapted and integrated into care. And so you're really walking the line between disease-modifying therapies and integration of this more person-centered approach from time of diagnosis, ideally, and throughout the journey of care. And since about 2007, there's been 7, and increasing everyday studies showing that integration of this person-centered approach early in the trajectory of care improves quality of life. It improves mood. There's less depression and anxiety for both the patient and surviving family members. And in about a third of those studies, there's actually improved survival. So palliative care now is no longer something that's synonymous with end-of-life care. It's a skill set that brings life into the days left to you to live. So let's look then at the physician-hastened death kind of facts and figures across the world. So globally, as we've mentioned, in Oregon, the Dying with Dignity Act was the 1998, and it's about 0.5% of all deaths. About 150 out of the 30,000 deaths a year in Oregon occur as an outcome of the physician-hastened death. And I looked at the 2015 stats. There were about 236 prescriptions filled, and about 150 people actually went through with taking the prescription. In Oregon, as Heidi mentioned, you have to be competent and terminally ill to ask for a prescription, and then you ingest it yourself. Most are men, most are college educated, 81% have cancer, and 93% are enrolled with hospice. So even with ideal palliative care, there are still some people who elect this way of dying. In Washington State, I think this is interesting, there was a cancer center program who implemented the Dying with Dignity Act when that became legal in that state. And over 2.5 years, they had 114 patients who inquired about this. About 40% of them never went further than an initial conversation. About 26.3% actually went ahead and followed, but they started it but didn't pursue. 35% received prescriptions, and 60% of those ingested the lethal dose as a means of death. So that's 21% of the total. Sometimes when you listen to the media, it's like everyone who asks needs to be accommodated immediately. And lots of the stats across the world suggest that people ask for lots of reasons, and we need to do assessments as to why that is and what that means in terms of that patient. In Belgium, euthanasia, physician-administered hastened death is up to about 4.7% of deaths, but we know from some studies that there's about another 1.3% of deaths that are performed without consent in that country, so it could be up to 6%. These are the reasons in Oregon why people chose the Dying with Dignity, as it's called there. Losing autonomy, less able to enjoy activities of life, loss of dignity, loss of bodily functions, perception that they were a burden, and that pain, either present pain or concern about future pain, was only an issue in about 15 to 20%. So the first column is what happened in 2010, and then the last column is over the 13 years of the program, and 1 to 3% were for financial reasons. Desire for death in Canada. So obviously these are earlier studies prior to the legislation. Out of about 400 cancer patients in 8 palliative care programs from across the country, about 70% of them identified no desire for hastened death. About 20% of those had a psychological disorder by testing with depression and anxiety. Out of the 30% who expressed some desire for death, but in many people it was transient. I wish this was over. Why is this taking so long? Those kinds of comments that we may hear from our patients from time to time. In about 12%, there was an apparently genuine desire to die, and when that 12% was analyzed, about half of those met the criteria for depression or anxiety. So out of the people who request hastened death, potentially about half of them may have something that's treatable in terms of anxiety or depression. And even out of those who have a genuine desire for death, only about 40% of them would opt for euthanasia. In the Netherlands and Oregon, about 8 to 47% had depression. So the studies are continuing and looking at what percentage of the time is there a treatable psychological issue. Sorga did sort of more of an in-depth qualitative analysis and described the wish to die on a continuum from I have no wish to die to this kind of sense that maybe, I wish it was over, to being actually somebody who's moving towards that. And in most cases, there was a specific factor or a trigger. So it's important to ask about why now? What's happened to lead to this request at this time? Most often, this wish to die was part of a larger narrative, kind of consistent, and that's what the Oregon studies are showing us, consistent with how they've lived their life, usually highly independent people who fear dependency more than death. They don't want to be dependent on other people. They don't want to have the supports that may be available. And social interactions were a huge factor. Sometimes just, I'll show those people or, I'll prove to them something. So we really do have to look into this. This other study looked at sort of a group of patients and looked at sort of the constellation of the themes that were identified. Often the suffering, which is one of the criteria. Loss of self, that they don't feel like themselves. They're afraid of dying. What will it mean? They want to live, but not like this. Death as a way of ending suffering, and hastening death as a control over your own life is quite a common theme that comes up in most of these studies. So again, just pulling that apart a little bit and trying to say, help me understand what's going on for you. In a palliative care hospital in France, surrounded by Belgium and Luxembourg and all the countries where this is legal, in about over 2,000 admissions over a 2-year period, only 9% had an expression of a wish to die, and only in about 0.3% this was persistent. So with the implementation of a palliative approach to care, you can change the numbers. You can decrease the amount of people who are asking for this. You can decrease suffering. You can change that perception that nobody cares. I don't have the right social supports. By providing the social supports that are needed, sometimes you can change the numbers. So they were saying if somebody's talking about this, it's a signal to us as healthcare providers to kind of press in a little bit, to pay more attention to what's going on and to ask what's going on. So how do we respond? We need to respond professionally and compassionately. These are suffering patients, and we need to understand why, to see whether there's things we can treat or manage or help them understand in different ways, to debunk some of the fears and myths around palliative care, dying, etc. We can respond to specific issues, and we need to always be documenting throughout, as Heidi said. Provide a roadmap. Are we looking at months, years, days, weeks? What is still ahead for them? Help them understand the benefits and burdens of options and be clear about that. Is prolonging life a goal or a value, or is other things more important for them? To help with care planning, connecting them with home care, nursing, or palliative care, or other support services so that they feel the social supports that may be lacking in their family environment. And when is it appropriate time? So for ALS patients, a natural time to make a decision not to prolong life is to not go on a ventilator when they're at a certain point, or not to go on dialysis. So there are these natural times when they can choose not to start certain treatments that may prolong life. And always mean us not abandon our patients, and we need to focus on the issues that they have. We need to not normalize dying. It's part of the cycle of life, and this isn't about giving up. This is about actually finding the supports to walk this journey. That dying is usually peaceful, not painful. Dying can be in a well-supported environment, but you need to be truthful and honest about the real risks that they may be facing, etc. So palliative care and integration of the palliative approach can enable quality of life throughout a continuum of care, and introduced early improves outcomes. Some of the different initiatives we're working on, one of which is compassionate communities. We can extend this kind of listening ear to our neighbors and colleagues and others, not just doctors, nurses, and healthcare teams, but everyone in a community. And this is a quote from the founder of modern palliative care: "You matter because you are you, and you matter to the end of your life. We will do all we can not only to help you die peacefully, but also to live until you die." Thank you.